Welcome to Conference Highlights, recorded in front of a live audience at an evidence-based perioperative medicine, that's EBPOM conference. EBPOM are world leaders in perioperative education, so why not join us at our next meeting with a special discount for Top Med Talk subscribers. Look us up on www.ebpom, that's EBPOM.com. Top Med Talk.
Thanks very much, and thanks very much for the invitation to this meeting. I'm going to try and stick to time. I have got some conflicts of interest. I have had funding and grants from various people, including the two manufacturers of intravenous iron, who are Pharmacosmos, who are sponsoring this meeting, so thank you to them, and also Vifor Pharma. And I think collaboration with industry is a good thing, and they've given us money and support for various studies in consultation with various national bodies. My other conflict of interest is I'm a part-time anaesthetist. I only do 50% of my job plan. The other half of my time I'm the editor-in-chief of Anaesthesia, which is the friendly journal, and we're proud to announce our impact factor is shooting upwards. It's well over 5 now. We've massively overtaken ANA, which is going downhill, and we're hot on the heels of another British journal. And we'll give you an answer in 2 weeks, which most other journals won't. So if you have anything interesting, just send me an email and we'll happily talk to you about it. So these are the learning objectives in the next 19 minutes. We're going to define anemia, look at different patient groups, especially women and elderly patients, and talk a little bit about the causes and consequences. And this follows on very nicely from Ramani's talk and the importance of this in our pathway. I'll tell you a bit about our pathway at Papworth and other pathways we've helped set up. And I have another disclosure, is this is, in an EBPOM meeting, an evidence-free zone. In other words, there are no level 1 trials like Paul and the others have presented. So the level 1 trials are in progress, and I'll tell you a bit about those at the end, but there is no grade evidence. So if you want to just ignore the next 20 minutes because you only like grade A evidence, that's fine. But actually, this is important. It's important to the NHS and other healthcare settings because it has been shown to save money and reduce transfusion, but the importance on patient outcomes hasn't yet been proven. That's a disclosure that you need to bear in mind. So you probably know this. You're going to be inspected by the CQC over the next 12 to 24 months, and this is now a NICE quality standard. So much of what I'm going to talk to you about is NICE have shot the bolt. They have said this is a quality standard of care in the UK, that patients should have their anemia managed actively before surgery. That is before level 1 evidence. Now, NICE is all about great evidence begets change, but actually, because of the money side of things, they've shot the bolt and actually made it much more difficult for us as researchers to do the level 1 randomized controls trials, because they've said that patients should have this treatment. So a NICE quality standard, as you probably know, affects everyone who works in healthcare settings. It affects the managers, it affects us as doctors and nurses, it affects the commissioners who pay for service, and it affects the patients themselves. So patients can now sue us and say, you didn't manage my anemia, why not? So this is an important thing. This quality statement came out in February 2017. It applies from February 2018 because you get a year for derogation. And NICE say you have to be doing this. And when the CQC come and inspect you, there's a list of 112 quality standards that you have to apply. And your managers should be all over this. So if they are all over this, how many of you in the audience have a anemia clinic or iron clinic in your NHS hospital? So it's getting better. Last year I would have said it'll be less than that. Probably it's about 25% of us in the room. We do at Papworth, and I'm going to use that as an example. But I would say in a couple of years' time that number will be much greater. This is an up-and-coming thing, and as Ramani illustrated, it's important. So EPO is out, according to NICE. You shouldn't be using it. There's no evidence for it in the perioperative setting. Iron is in, both oral and intravenous iron. So oral iron if you've got plenty of time, and I'll talk a bit more about that later. And intravenous iron if you haven't got enough time. There are specific patients groups that won't benefit from oral iron, particularly cancer patients, particularly patients who've got only a week or two before surgery, particularly those with iron of chronic disease and a high hepcidin, which I'll talk about. So iron is in. Which patients? Anyone having big surgery. So we're not talking about toenail removals, varicose veins, hernias, tooth extractions. We're talking about big surgery. So laparotomy, thoracotomy, stenotomy, gynae, hysterectomies, obstetric caesarean sections. So anything pretty big, which makes up over the UK about 450,000 major procedures a year. So we do about 4 million surgical procedures, of which about 10% are major, and it's 450,000 operations. So it's a lot of patients undergo pretty major surgery in the UK each year. So NICE say we should be doing it for all these patient groups. This is the WHO definition, which was made up by a bunch of 7 men in 1968. And you can see one thing, it's inherently sexist. Okay? And it's complete and utter nonsense. It's based on population normals rather than targets. And if you use this as a target for your anemia management, you're actually doing all the women who you're looking after a disservice. Why? Because women are inherently smaller than men and they're built differently. They have a lower body surface area and they actually have less total blood volume per body surface area, per metre squared of body surface area than men. So a 70-kilo man would have a total blood volume of 3.5 to 4 litres, and a woman would have 3 to 3.5 litres if she was 70 kilos. So what it means is, when a woman bleeds, and women bleed just as much as men, she will lose proportionally more red cells out of her total red cell mass and become more anemic for the same amount of blood loss. So actually, women need to be optimised better. And in fact, what we probably should be doing is completely reversing this and maybe targeting a haemoglobin of 13 or even 14 in women, whereas men can tolerate blood loss better than women. That is not surprising because if you look at transfusion in major surgeries, it's double in women. So in cardiac surgery, we transfuse double the amount of women than men. And we published this paper this year in a very good journal, and we showed that transfusion in women was 60% and in men was 30%. So women are twice as likely to be transfused, they stay longer in hospital, and their mortality is higher. So women are less likely to undergo cardiac surgery, they have better hearts, less atherosclerosis, less coronary artery disease. But if you are a woman and you need major surgery, you're more likely to be transfused and your mortality is higher. So if you're a woman, don't go and see a surgeon. And this borderline group of 120 to 129, which we call the forgotten tribe, which is about a third of women, they don't get optimized, they bleed and they're transfused a lot, 70% of the time, and they stay longer in hospital and have worse outcomes. So in fact, we should be targeting women proportionally more than men and to a higher target. Okay, what about the elderly? The elderly are different because the proportions of anemic patients change as you get older. You get more chronic disease, your hepcidin goes up because your burden of disease, and your haemoglobin falls naturally. It's part of the natural aging process. Aging is a pro-inflammatory state, unfortunately. The older we are, the more inflamed we are, the worse our coronaries are, the worse our kidneys are, diabetes, all those things. And so therefore our haemoglobin falls. It doesn't in women because obviously they stop menstruating, their periods stop, their hormone levels change. But in men our haemoglobin goes down much more markedly in the elderly. And in the elderly, anemia is much more significant. So if you're 25 and your haemoglobin is 9 or 10, you feel like crap, but you still get on with things. If you're 75 and your haemoglobin is 9 or 10, you feel like crap, but you can't do anything. You can't mobilize after surgery. You just feel tired and lethargic and awful. So actually, all these things in the elderly, much worse tolerated. And this is an illustration of the pattern of anemia changes. So I'm lucky still to be in the 17 to 49-year-old group. I've got about a 1 in 100 chance of being anemic. But my father, who's in the 75 to 84-year-old group, he's 15 times more likely to be anemic than me because the pattern of disease, the burden of disease changes, and therefore anemia becomes much more common in elderly men, whilst in younger women, and this is obvious really, it's much more common. So in this audience, I would say out of the women in this audience, about 20 to 25% of you are anemic. Okay? That's very, very common in women who have heavy periods, women who run and do boxercise. All those things reduce your haemoglobin, and women who've had children. So that group, if you're a woman who has heavy periods and you've had children and you run, 99% of you are anemic. So we've done studies in the London Marathon. We looked at the top 100 women in the London Marathon. So these are hugely elite athletes, Olympic standard athletes, women, and a very high proportion of them, 70% were anemic and iron deficient. Then we treated them with intravenous iron and put them on an exercise bike, and lo and behold, they improved by about 12%. So for women, the burden of iron deficiency and anemia is very, very high, whereas in the elderly, it's much more prevalent in men. So why? This is what we learned about in medical school. Iron, folate, B12, kidneys, and chronic disease. This 1/3 to half of patients that have chronic disease. And we didn't really know why patients with chronic disease have anemia, but we know a lot more now. And we have 3 or 4 grams of iron in our body, and we need 1 or 2 milligrams a day. That's the equivalent to about a quarter of a beef burger or 2 kilos of spinach. And if you're a vegetarian or a vegan, you need to eat a damn hell of a lot of spinach or other things like tofu that have iron in. So if you're a woman who's a marathon runner and a vegan and you've had 2 children... So we get a lot of vegans and vegetarians who are anemic, unfortunately, take supplements. But 50% of people don't absorb the iron in their supplements. So really, if you are a vegan or a vegetarian, I would recommend you to take your supplements that you should be doing to supplement your diet, because you only need a tiny amount of diet, but it's very, very difficult to get that amount of iron in a vegetarian diet, or drink lots of red wine. So you lose iron in your sweat, athletes. You lose iron when you run because you strike the ball of your foot and damage your red cells. You lose iron through your periods, through your intestines, and through your kidneys, or through your bladder, and you absorb that 1 to 2 milligrams a day via ferroportin and transferrin, which carries the iron around. And hepcidin is the central regulator. It's a small amino acid peptide. This is the physiology bit, my apologies. It binds to ferroportin and stops you transporting that iron around. So if your hepcidin is high, you won't transport that iron from your gut to your storage sites, and you won't transfer it and make red cells. So you have an iron deficiency that leads to anemia, that leads to all the problems. So the central regulator is hepcidin, and it starts off that you get iron deficiency because you can't absorb it, then you can't utilize it, you get these thin, measly red cells that don't carry oxygen around, and then the disease progresses and you get anemia. So anemia is actually quite late in the disease process. And this explains chronic disease, because as you get chronic disease, your hepcidin goes up. So if you're fit and well, your hepcidin is 1, 2, or 3. But if you have kidney disease, it's 30 or 40. If you have diabetes, it's 10 or 20. If you have chronic heart failure, it's 50 or 60, which explains why nearly everyone who has chronic heart failure has got iron deficiency anemia. The cardiologists are well into iron for heart failure. Improves, FAIR-HF trial in the New England 4 years ago, improves the degree of heart failure by 1. So from grade 4 to grade 3, or grade 3 to grade 2. So iron is very, very important for cardiologists, very, very important for renal physicians. All patients with chronic kidney disease get intravenous iron. They get grams and grams, stacks of it each year. And gastroenterologists for Crohn's and ulcerative colitis patients. But we as perioperative physicians are well behind the curve compared to those physicians, the gastroenterologists, the kidney doctors, and the cardiologists. So anemia of chronic disease is iron deficiency. It's functional iron deficiency or iron restriction anemia. So that ties it all together. That's the physiological explanation for the iron deficiency that we see with chronic disease. So we did an audit, a quality improvement exercise, if you like. We looked at about 12 cardiac centres in the UK, all over the UK, thousands of patients, and what we found is that across the UK, in cardiac surgical patients, about a third are anemic. That's not surprising. That third comes up again and again. In colorectal surgery, it's about 50%. In gynae surgery, it's about 60 to 70%. In urology surgery, it's only about 10 to 20%. But overall, in patients having major surgery, it's about a third, and it's almost exactly a third in cardiac surgery. And there's some national variation. So Cambridge, we're the dot on the right, and that's number 5. So we have the highest proportion of anemic patients in Cambridge, the UK. Why? Is it because we don't eat enough spinach in Cambridge, or there's more vegetarians and vegans in Cambridge? No. It's because we have a higher burden of chronic disease because we're a national referral centre, so we get all these really sick patients that no one else wants to operate on. Whereas in Belfast, they have the lowest incidence. They're number 4, less than half of Cambridge's incidence. Why? Because they're younger and fitter when they go for their cardiac surgery in Belfast and Northern Ireland. So you can debate with your Irish colleagues as to why they're younger and fitter in that population cohort, but that's the way it is. Now, that's important if you're designing a major trial. We found this with our ITAX trial, that certain centres around the world that are doing intravenous iron trials, they're finding we've got no anemic patients, or we've got stacks. And that difference is because of the socioeconomic status and the chronic disease burden in those centres. And it's very, very interesting. And you need to know this when you're designing or conducting a trial, because the incidence of anemia is critical for the design and implementation of that trial. So knowing that there's this variation in the UK, and we're just starting a trial in Europe where we're looking at loads of centres in Europe to see what the variation is. Is there more or less anemia in France or Italy or Spain or whatever? They've all gone home from the World Cup. No, sorry, France haven't. England, France in the final. So apologies to the French audience. So anemic patients, twice as likely to be transfused. They stay a day or two longer in hospital, a day longer in the ICU. And this is your business plan. A business plan is about looking at the environment you're in, looking at your outcomes, and then defining it and defining what the savings are in terms of managing those patients. So this is your business plan. You need a local audit, a national audit to define your population and your transfusion outcomes. If you're red, you're transfused much more likely than if you're blue where you're non-anemic. And you can see there's this inflection point at 13 or 130. So 13 and above is normal. Below means that the mortality goes up logarithmically below that level. So 12 is bad. 11 is 8 times more likely to die after cardiac surgery. So it's very bad. That's an association. It's not a cause. But the associative thing is the more anemic you are, the worse your outcomes. And it's the same with length of stay. It's a 40% increment for every 10 decrease in hemoglobin. So 130 to 120, 120 to 110. It's a 40% increment for each decrease. That's not just cardiac. Big studies have shown the same in all sorts of surgeries. This is general surgery, big study in the Lancet, 230,000 patients. The lower your hemoglobin, or the higher your hematocrit, the worse your complications rate and your mortality. So 13 or 130 is that dot on the left. Very low mortality, very low complication rate. And as soon as you go up above that, so 130 is the incremental rate, which fits what I was talking to you at the beginning about how you need to define that in both women and men. Okay, 200 patients, we did bone marrows, every single blood test known to haematologists, which is a lot, believe me, and very expensive. 85% of our patients, 84 to be exact, were iron deficient. So I've told you a third of patients are anemic and 84% of patients are iron deficient. So the clinic you need is not really an anemia clinic, it's an iron clinic. And that's what we call our clinic at Papworth, it's an iron clinic. Patients undergoing cardiac surgery and every surgery in the UK are iron deficient, and that's the cause of their anemia. So what you need is to change your pathway. So perioperative care is about looking at your pathway, in my view, changing it to allow you to optimize your patient. So not just measuring the hemoglobin a week before surgery in the pre-op clinic and then ignoring it, but getting that hemoglobin 4, 6, 8 weeks earlier, getting it to the people, telling the patients, bringing them in and managing them, or working with your primary care doctors to manage them. So their hypertension, their smoking, their bad diet, their lack of exercise. So Mike was talking about exercise prehabilitation. You can't do that if you have your pre-op clinic a week before. You can't get them on a bike and make them fit. You can't make their anemia better in a week. But you can if you move your pathway and you move your hemoglobin result. So in our surgical clinic, they see a surgeon, the surgeon says, yes, you've got coronary disease, you need bypass grafts. That's when the surgeon loses interest. They dictate their letter and they go on to the next patient. The patient goes home. 3 months later, they have their surgery. And they say, thank you very much. No. They see the surgeon. The surgeon says you need surgery. And then we accost them in the waiting area before we go home. We get a phlebotomist. Actually, what we do is we screen their HB on a RAD67, one of the Massimo devices, and I have no financial interest in it. And if their hemoglobin is less than 13 on the point-of-care device, we do a full blood count, ferritin, transferrin sats in the surgical clinic. We look them up. Every Tuesday, we get all the patients who've come to surgical clinic, we look up their results on a Tuesday, and we send them all letters, and we manage their anemia actively. It's all about changing your pathway to enable you to do that earlier in the process. So, ferritin less than 30, iron deficiency. Barn door, bang, forget it. 92% sensitivity, 98% specificity. And if it's less than 15, we did top and bottom scopes because they're pretty likely to have some sort of chronically bleeding lesion, which you need to find out. Sometimes after cardiac surgery, sometimes before. But ferritin less than 30 is easy. They need lots of iron. Ferritin 30 to 100 is also iron deficiency if the transferrin sats are less than 20. So ferritin is acute phase reactant, and it can go up because of the acute illness. Most of these are chronically ill, so that doesn't matter. But if they've got some acute illness going on, their ferritin will go up. But if the transferrin sats are less than 20, then also they've got iron deficiency. So basically, we just do ferritin and transferrin sats. Now, haematologists will argue till the cows come home, until England win the World Cup, about how you diagnose iron deficiency. And I don't want to get into a debate with any haematologists about it. This is the way we do it. You can do it on low-density hemoglobin. You can do it on reticulocyte count. You can do it on anything. But ferritin and transferrin sats are the way we do it. And we published a consensus statement, also in a very good journal, which basically is a how-to guide. So what the questions you need to ask is who you're going to treat, HB less than 13, where. We do it in our day ward, our thoracic day ward, because patients have their bronchoscopy in the morning, and in the afternoon the nurses drink coffee and eat biscuits, and our thoracic day ward is empty. I'm very unpopular because in the afternoon, on a Wednesday and a Monday, they now give intravenous iron and they can't drink coffee and have biscuits. Day wards are perfect because they've got couches, seats, monitors, nurses. They put in a blue cannula, they get 1 gram to 1.5 grams of iron in 15 to 30 minutes, a cup of tea, and then they go home. But you could use your clinic, your outpatient clinic, if this is set up for that. In Norfolk, they have an iron van where it goes around all the different towns of Norfolk because they've got geographical issues, and patients who are referred for the iron clinic get their iron in a van. So whatever has some monitoring, some nurses, some medical backup. So oral iron takes time, 6 to 8 weeks. Oral iron, has anyone ever had it before? Horrible. Makes your stools black, gives you constipation, tummy pain. Why? Because we give far too much. So 200 milligrams 3 times a day, far, far too much. That's the standard GP prescription. It should be 60 to 80 milligrams every other day. 200 milligrams, your hepcidin goes up, you don't absorb the next 5 doses. So you need 60 milligrams, and then give it 2 days for your hepcidin to go back down, and then you'll absorb the next dose. So you need less iron, less frequently. It's 6 weeks to start to see a response, and 3 months to get a maximum response. No point starting it 2 weeks before surgery. And there is absolutely no point starting it in your post-op patients. Our orthopaedic surgeons used to love to say 200 milligrams 3 times a day post-operatively after hip replacements and fractured neck of femur. Your hepcidin is up for 6 weeks after surgery. You don't absorb the oral iron. Nobody takes it. Absolute waste of time post-operatively. Intravenous iron, we give to patients who have got less than 4 weeks for surgery. We give them as much as we can. We use 20 milligrams per kilogram of Monifer because we can give a lot more of Monifer than we can of Ferinject. We can give 1.5 to 2 grams of Monifer in a single setting. So that makes it much more cost effective for us because we just have a single one-stop shop. We have their ferritin transference. Give them as much iron as we can. So about 1.5 grams of Monifer is a year's worth of iron in one dose. Side effects, anaphylaxis is rarer than penicillin. Much rarer than England winning a penalty shootout. It's incredibly rare. It used to be common with old preparations, but it's very rare with the new preparations. So mild side effects are quite common. Bit of red face and tachycardia, a bit like vancomycin, about 1 in 20. Bit of hypotension, 1 in 100. If you stop the infusion, wait 5 minutes and start it up again, it's fine. Anaphylaxis, incredibly rare. We haven't had any side effects. I haven't had to give steroid. We've given about 300 or 400 doses. We haven't had any problems with it. So I'll just show you some patients. Last 13 we had at Papworth, and you can see their haemoglobin before their iron, and then their haemoglobin about 6 weeks later. It's gone up by about 15 to 20. So it's gone from 110 to about 125 or 130. You can see those who have very severe anemia, you had the best effect, 87 to 118. 87 would definitely have been transfused 2 or 3 units of blood. But at 118, there's a good chance they won't be transfused. So this makes a big difference. We've cut our transfusion rate by 50%. So we transfuse now 20 to 22% of our patients instead of 40 to 45. So it makes a huge difference. It's obvious. If you start higher, you have on bypass, you give a bit of fluid on bypass, 2 litres of crystalloid and so on and so forth. If you start higher, you finish higher, and you're less likely to transfuse. So I've told you about our patient journey. Money. Dirty word? No. 100 patients I see in the clinic, £128,000 saving for the hospital. So this is our SIP. We call it Service Improvement Plan. We see 250 patients a year. I save 250 grand for the hospital. I'm very popular. You too can set up a clinic and save your hospital lots of money. So in cardiac surgery, those are the savings that we've demonstrated. It's a big saving because of length of stay, because of ICU usage, and because of transfusion. That is why, fundamentally, NICE have said it before the level 1 evidence. So PREVENT, which hopefully some of you will have taken part in, which is intravenous iron versus placebo for general surgery, urology, gynae, colorectal, nearly finished. 467 patients as of this week out of 500. Be finished in September, so it'll be published very soon, March, April, I would say. Other people might say April, May, or June. But that's going to show transfusion rates and major outcomes for general surgery, and then ITACs, which is cardiac surgery, which Paul and I are doing, along with loads and loads of other people. So thank you to all the centres who are taking part. There's 27 centres going now. We've recruited 160-odd patients so far. It's intravenous iron versus placebo before cardiac surgery, looking at days alive and out of hospital. So in 3 years' time, we'll have the level 1 grade A evidence for intravenous iron before cardiac surgery. Next year, we'll have it for general surgery. So the evidence is coming, but it's not there yet. And I would really ask you to engage in these trials because Although I've told you some good things and some interesting things, we really need to look at patient outcomes. It's the whole point of this meeting. And there is equipoise with regards to patient outcomes. So we really need to engage with these trials for cardiac surgery, ITACs, for PREVENT and any other trials that are going on. And that's really the end of my talk. Engage with the level 1 evidence, engage with all the trials you're hearing, because this is really what makes a difference. And anemia, very common. If you're a woman and a vegetarian and a runner, come and see me afterwards and I'll give you some iron. Thank you very much.
Thanks for downloading and listening to Top Med Talk. Don't forget to find us on social media. We're on Twitter, Facebook, Instagram, even got our own YouTube channel. Whichever your favourite social media feed is, we're bound to be there. Find us. Also, subscribe to this podcast so that you never miss an episode. And make sure you go to the Top Med Talk website, topmedtalk.com. and get on board with the email updates. Oh, whilst you're at it as well, I suggest you download our entire back catalogue. We're categorising at the moment. We're having a little look through it. It may not always be in the form that you currently find it. So if you get your hard drive ready for a full-on download via the website perhaps, or perhaps through your podcatcher. Oh, and if you fancy meeting us, why not go to the website ebpom.org/meetings. Our next big event is EBPOM USA, the Dallas Masters Course, a perioperative care practicum. Have a look for details of that and some of the other meetings coming up across the next year. ebpom.org/meetings.